Welcome, everybody. You can see everybody starting to trickle in. First of all, thank you all for joining. It's a very warm day. I'm sweltering here, so please bear with me. But the topic of today's webinar will be on molecular profiling. My name is James Badman. I will be supporting with the moderation today. And my role mainly is to keep us on time, but also to work with our brilliant speakers here to meet our objectives. On that note, as I said, I am joined by our speakers today. I will first of all hand it over to Helen. If you're okay to do a quick introduction, Helen, not that you need to, but that'd be brilliant just to get us going.
Thank you very much, James. Well, good evening, everyone. I'm Helen Morment. I'm the Chief Executive at AMMF, the Cholangiocarcinoma charity. I'd like to welcome everyone joining us this evening for our special webinar, Unlocking the Power of Molecular Profiling in Cholangiocarcinoma. And this webinar is going to provide us with a brief introduction to genes and genomes, laying the foundation for understanding molecular profiling and its implication for the treatment of cholangiocarcinoma. We're going to explore the specific tests commonly used, the most frequent mutations identified, and the targeted therapies currently available. So a lot of good stuff for us this evening. And on behalf of all of us at AMMF, I'm really delighted to welcome our key speaker this evening, Dr. Matt Evans, and also Professor Chiara Bracconi, and of course, our cholangiocarcinoma patient advocates, Kevin Roger and Ilona Smith. We're hugely grateful to them. Now I'm going to hand back to James, who's going to ask each of our panel members to briefly introduce themselves. Over to you, James.
Thank you, Helen. Brilliant. I will start with you if that's okay, Matt.
Good evening, everyone. My name is Matt Evans. I'm a consultant molecular pathologist based predominantly in Birmingham. My other role, though, is that I'm also pathology lead for the Central and South Genomic Laboratory Hub, which delivers genomic testing to patients in the West Midlands, Thames Valley, and the south coast of England.
Thank you, Matt. And I'm not going to play any tricks and just jump to the end. I'm going to work my way along the line. So if it's okay to go to you next, Chiara.
Good evening, everyone. I am Chiara Bracconi. I'm a clinician scientist at the University of Glasgow and a medical oncologist at the Beatson Cancer Centre in Scotland, where I lead the biliary tract cancer clinic.
Thank you, Chiara. And then over to you, Kevin. And I know you did recently speak at the conference. It was a very powerful talk. So thank you again for everything you're doing with AMMF.
Thank you, James. Good evening, everyone. My name is Kevin Roger. I've been a cholangiocarcinoma patient for about 3.5 years. Like many of you out there, probably undertaken similar journeys: chemotherapy, radiotherapy, surgery, and now immunotherapy.
Thank you, Kevin. And last but not least, Ilona, if you could do a quick introduction.
Hi, everybody. My name is Ilona Smith. I was diagnosed in 2020 with cholangiocarcinoma, and I'm currently on targeted therapy, and I'm here today because molecular profiling was used in my case. I live in London currently, and yeah, great to be here. Thank you for inviting me and having me here.
Thank you very much. So moving on then, just quickly in terms of the flow of the session today, it will be 90 minutes long. We are currently working through the welcomes and objectives, but beyond that, there will be 3 parts to the webinar. The first one will be a presentation from Matt Evans, so on the role of molecular profiling cholangiocarcinoma. We will then have a moderated discussion by Kevin and Ilona. Hopefully they will keep Matt and Chiara on their toes and ask some pretty good questions that will help, the conversation and just go a little bit deeper into some of the slides that Matt will present. We will then close with a Q&A. So we will open the floor up to the audience. So I do encourage you throughout this webinar to use the Q&A feature towards the bottom of your screen. Please do submit your questions, and we will use that last 30 minutes to really dive deeper into some of the questions. We will then close the webinar at 7:30, just in time for dinner for some of us. Yeah, so again, thank you all for joining. So before I hand it over to Matt, in terms of the housekeeping, as I said, there will be a Q&A session towards the end of the webinar. Please do use the Q&A feature towards the bottom of your Zoom. You can ask a question there, and we will then be able to see that as speakers in the webinar. We'll do our best to get them answered. If you are experiencing any technical issues at all, you can use the chat function, and someone in our team will be able to reach out to support you. If you do need to step out or you miss any parts of today, it will be recorded and made available on AMMF website. So no problem if you need to step out. You'll be able to see it in the next couple of days. In terms of the purpose of the webinar, so what we're trying to achieve today is to provide you with the information on molecular profiling and, importantly, the implications for the patient community. This is the second webinar in a series of webinars by AMMF, and I'm sure we'll talk about it later. There are many planned in the future, but the first one was on clinical trials. So if you did miss that one, you can visit AMMF's website to see that, and you'll be able to see a great presentation by John Bridgewater. Again, as I said, there will be a Q&A session towards the end, so please do get your questions in. I'll keep reminding you. Thanks again, everybody, and I will now just hand it over to you, Matt, if that's okay, and you can start your presentation.
Perfect. Thanks very much, James. Huge thank you as well, of course, to the AMMF for inviting me to speak. It's always an enormous pleasure to be able to contribute to events like this. But really, thank you to all of you for taking time out of a very sunny and lovely evening to listen to molecular genetics, which is no small feat. As you've already heard, what I'm going to be talking about here is molecular profiling in cholangiocarcinoma. And I should probably begin with a bit of an admission, really, which is that I'm not actually a cholangiocarcinoma pathologist. In a sense, you've kind of been a bit shortchanged. I'm a molecular pathologist, and 5 years ago, what I dealt with was lung cancer, lymphoma, those kinds of diseases. And really, cholangiocarcinoma was not on my radar at all as a molecular pathologist, because even 5 years ago, there wasn't really a huge amount there. Things have changed dramatically now, and actually fast forward to today, and cholangiocarcinoma actually occupies quite a large portion of every one of my working days, which I think is an illustration of just how quickly molecular profiling has become such an integral part of this disease. And I think we've never really seen that degree of change in any cancer before. If I could have the next slide, please. So let's start with the very basics. What do we mean when we talk about genomics and genomes? Well, you'll all be aware that human bodies are made up of cells, and each cell contains kind of a recipe for making you in the form of genetic material. And the sum of all the genetic material in a person is called the genome. So it's basically the entire recipe book for making you. Now, that recipe book is written in a language called DNA, which I'm sure you'll all have heard of. And that DNA is organized into structures called chromosomes. So you have all of the DNA in your cell, it's packaged up into little chunks called chromosomes. The way I like to think about it is that you have your bookshelf in the kitchen with lots of recipe books on it. That's your genome. Each of those recipe books is a chromosome. And then if you open up those books, you'll find multiple different recipes, which are the genes, which go on to produce all the different parts of you. Next slide, please. So that's what I mentioned a moment ago. Each of those chromosomes contains multiple different genes, the individual recipes. And each of those recipes is a recipe for making a protein. And proteins are kind of like the business part of our cells. They're the bits which actually get things done. So they might break down substances, they might create substances, they might drive a cell to start proliferating or growing more rapidly. They might tell a cell to stop growing so rapidly. A gene will encode one of those proteins. Next slide, please. Now, that's how things are supposed to work. But our bodies are constantly being subjected to insults from the environment. So, for example, if you step outside into the sunshine, you're going to be exposed to UV radiation. Now, a little bit of UV radiation is a massive problem, but if you get a lot of it, that can cause problems with the recipe books that make up your cells. It can change the sequence of your DNA. And that's what we call a mutation. And you can get that from things like UV radiation, like chemicals in the atmosphere, in the food, etc. It's part and parcel of being alive. You will sustain mutations. Now, fortunately, most of those mutations, those changes in your DNA sequence, will have absolutely no implication at all. Our cells are very clever and our genome is very clever in that it kind of has built-in mechanisms to resist the impact of mutations. But sometimes mutations will lead to important changes in the DNA sequence. Those changes in the DNA sequence will change the structure of the protein that those genes produce. And that change in the structure might result in that protein working in a different way. So you can see in the illustration here, you've got your normal gene producing a normal protein. If you have a mutation in the gene, well, you could end up producing a protein which is abnormal in some way, or it might cause so much damage to that bit of DNA that actually you don't produce a protein at all, and it might knock the whole thing out altogether. Next slide, please. So that all sounds very theoretical. Why does it matter in practice? Why does it matter in the context of cholangiocarcinoma? Well, some mutations have the potential to cause cancer. So, for example, if you have a gene whose normal function is to promote cell growth, if you have a mutation which means that that gene is always switched on, well, in that case, the cells which have that mutated gene are going to replicate and replicate and replicate uncontrollably, and that clearly could lead to a cancer. True. So if you have a gene whose normal function is down cell growth and you have a mutation which knocks out that gene, well, you're going to have kind of the same thing happening, but in reverse. You've taken the brakes off cell growth and cell proliferation, meaning that again, you're going to have uncontrolled cell growth, which could potentially lead to a cancer. Now, one of the difficulties which we face in molecular pathology is that things aren't normally as simple as just having a single mutation in a single gene. Generally, cancer cells will have multiple mutations, and often they'll have many, many, many mutations. And that can make things very, very complicated because they can all have slightly different effects. It may be, for example, that a single cell has multiple different mutations which promote uncontrolled cell growth. And in that case, it can be very difficult to be able to apply brakes on that excessive growth. The other reason that having multiple mutations is important is that, let's say that you have an initial mutation at the start of a cancer. That mutation might, for example, cause a cell to grow uncontrollably. Let's say you give that patient a drug which slows down that growth. And the problem is that that cell might go on to acquire another mutation in the future, which kind of bypasses the drug which you've given, causing the tumor to become resistant. And in that way, we're kind of always trying to play catch up with the cancer to try to control its growth. Next slide, please. So that comes to kind of the purpose of these few slides, which is talking to you about genomic testing. And as I say, 5, 6, 7-ish years ago, this wasn't really a thing which we did in cholangiocarcinoma. All that has completely changed now, and genomic testing is very much a standard thing which we do nowadays in cholangiocarcinoma, alongside a very, very long list of other cancers. This is becoming the default thing which we have to do for pretty much all advanced cancers nowadays. When we do genomic testing, in simple terms, what we're doing is looking at the genome of the cancer and looking for mutations within it. So we're looking for those changes compared to what we would expect the gene's recipe to look like. And we can do that genomic testing in a few different ways. The commonest way that we would do it, particularly in cholangiocarcinoma, is to take a piece of the tumor, so for example in a biopsy. We'll look at that down the microscope to make the diagnosis of cancer first of all. We'll then potentially do some more tests to establish what type of cancer it is, so cholangiocarcinoma. And then we'll use that tissue to undertake genomic testing to look for mutations. That is probably the default option at the moment. In some cancers, though, and increasingly in cholangiocarcinoma, we are also doing that testing in blood. So we take a simple blood sample, just like a blood test you would have done at your GP practice or wherever by a phlebotomist. But instead of doing the routine tests on that, we extract DNA from it, and we use that DNA to undertake the genomic testing. That's fairly new in cholangiocarcinoma, and there are some issues with it, but that I think is rapidly going to become a very, very important tool in our armory over the coming years. Now, the terminology with this is a bit of a nightmare, to be honest. You'll hear it described in pretty much every way you could imagine, but things like genomic profiling, molecular profiling, mutation analysis, genomic testing, these are all basically different ways of saying essentially the same thing. Next slide, please. So I think I've already alluded a little bit to this already, but why do we bother doing genomic testing? Why has this become such an important thing in cholangiocarcinoma? Well, I think it underlies what we've kind of always known, which is that yes, we have cholangiocarcinoma and we use that term as a diagnosis, but we've always known that cholangiocarcinoma is not really a single disease. It's actually a family of diseases which all have quite a lot in common, but actually behave quite differently. And in the past, it was very difficult to understand why those cancers behaved so differently. But genomic testing is showing us that actually at the molecular, at the DNA level, these cancers can show really quite significant differences, to the point where I would say these are different diseases under the same umbrella category. And I think it stands to reason that if you have multiple different diseases, as in what I'm saying for cholangiocarcinoma, giving all of those diseases the same treatment probably won't always have the same outcome. And increasingly, we're having to look at cholangiocarcinoma in this way and treat each of these tumors slightly differently depending on their molecular makeup. And obviously that is because a different person's tumor may have different sets of mutations. So a person whose cancer has this set of mutations may respond well to this drug. A patient whose cancer has a different set of mutations may well respond better to a different drug. Molecular profiling is all about that. It's effectively about personalizing a patient's diagnosis, personalizing their care. And that ultimately will allow us, at least to some extent, to give a more personalized idea of prognosis and a more personalized idea of what treatment is most likely to be effective for that patient's particular tumor. Now, I think it's important not to overstate this at the moment. In routine practice at the moment, there aren't huge numbers of mutations which we look for and that we can do very much about, but that list is growing and there are increasing numbers of mutations which we look for and increasing sub-diagnoses within that category term of cholangiocarcinoma. Next slide, please. So here I'm actually showing you the different mutations, and interestingly, the pattern of mutations differs depending on the subtype of cholangiocarcinoma, which kind of shows us that we were kind of right all along to subdivide cholangiocarcinoma in this way. So you'll be aware that historically and anatomically, we've divided cholangiocarcinoma into intrahepatic types, perihilar, and extrahepatic types based on where the tumor occurs within the bile ducts. Now, that, as I say, is reflected in the molecular pathology, because what we find is that there is really quite a distinct difference at the molecular level between intrahepatic cholangiocarcinoma and perihilar and extrahepatic cholangiocarcinoma. So in intrahepatic cholangiocarcinoma, the kinds of genes which we are looking for and where we tend to see mutations are things like IDH1, FGFR2. Now, this list only includes 4 genes. This list is actually pretty huge, but most of the individual mutations are rare. These are the big hitters. In terms of extrahepatic and perihilar cholangiocarcinoma, it's a really, really different pattern of mutations, to the extent that from the molecular level, as I say, these look like very different diseases. So in perihilar or extrahepatic cholangiocarcinoma, it's things like alterations in ERBB2, which you'll hear probably more often described as HER2, and things like BRCA, PIK3CA. Now, I think it's fair to say that at the moment, it's the intrahepatic mutations which we have more options for right now. But things are changing and there are more things on the horizon. But at the moment, these are the ones which we're most easily able to target right now. Next slide, please. So these are the targeted therapies which are currently available in England. And I don't want to tread on Chiara's toes here. She's far more qualified than I am to start talking about drugs. But I think all I'll say here is that, as I mentioned on the previous slide, most of the targeted drugs which we have available are really most applicable to patients with intrahepatic cholangiocarcinoma at the moment. So we have drugs which target IDH1 mutations and drugs which target FGFR2 fusions. The details of this don't matter very much. They're just different types of mutation. So, as I say, from the list of mutations which I showed you on the previous slide, those lists could potentially be enormous. At the moment, it's only IDH1, FGFR2, a couple of others actually, which we can target at the moment, but that list is growing. Next slide, please. So, having talked to you a lot about genomic testing or any of the multiple similar terms which we can use for it, what I'm going to do now is take a step back and look at a slightly different term which you may have come across, which is biomarker testing. And biomarker testing is a much broader way of describing things. A biomarker is, well, it's kind of what it sounds like. It's a biological marker, which doesn't actually say a huge amount, to be honest. It's just a way of measuring something in the body to tell us something about a disease. So within the category of biomarker testing, you have genomic testing, but you also have various other things, including things which you may already have come across. So CA19-9 and CEA testing in the blood, which can be used to assess a patient's progress. I think the key thing here is to say that no single biomarker on its own is perfect, and no test is perfect. It's very important that we bear that in mind. It's only by using a combination of these things that we can get the best picture of what is going on with a patient's cancer. And we also have to make sure that we're picking the optimal technology to be able to pick up these various biomarkers. Next slide, please. So, biomarker testing, as I said, is just a more general term for measuring anything in the body in this context to do with the cholangiocarcinoma diagnosis. A biomarker test could be used to tell you whether or not a treatment is likely to work. So, for example, that's what we do with genomic testing for IDH1, for FGFR2. Biomarkers may give us an idea of how likely a cancer is to grow and spread, so to give us an idea of how aggressive that cancer may behave. And they can also give us an indication of how well a patient is doing on their current treatment, so whether that treatment is working as we would hope that it would. Now, in terms of how you perform biomarker testing, well, there are loads of ways of doing it, which reflects the fact that it's a very broad term. So we could biopsy and do our biomarker testing on that, just like we do with the genomic testing. We could take a blood sample and use that, for example, for genomic testing, as I've already described, or we could use it for something like CEA or CA19-9 testing to check a patient's progress, or potentially other bodily fluids. And this is something which is being explored increasingly. Next slide, please. So, when and how should a patient with cholangiocarcinoma get tested? I think the first thing to say is in terms of treatment modalities, there are, of course, as you're aware, multiple different ways of treating cholangiocarcinoma. So it may be surgery, it may be chemotherapy, it may be immunotherapy, it may be a combination of the above. Now, the drugs which I didn't mention, because I'm going to leave that to Chiara, but the drugs which can be given as targeted therapies at the moment in cholangiocarcinoma are currently, at least in England, available in second line. So the point at which a patient with cholangiocarcinoma would, on the face of it, need their molecular profiling would be after their first line treatment when you're considering second line. Now, whether you would do that testing earlier is controversial. I think that's something that we could talk about later on. But the testing does need to be done at the latest after first-line treatment. Very, very important. The molecular profiling which I have described is available on the NHS for patients with cholangiocarcinoma. I know for a fact that that is true in England, Wales, and Northern Ireland. I will leave it to Chiara to explain the situation in Scotland, because I must say I've taken my eye off the ball a little bit with that. But certainly in England, Wales, and Northern Ireland, that testing is all available and it's funded. So I guess my plea there would be to say, and I think I'm going to come back to this again in a moment, please do ask about molecular profiling. It's very important that everybody involved in the care of a patient with cholangiocarcinoma knows that this is something which should be happening. You may very well be telling your clinician something which they already know about, but it never hurts to ask. Next slide, please. And this is a bit more detail about that. So a few questions which it may be worth asking your healthcare team. I think it's not a bad idea to ask, will you be using molecular profiling to plan my treatment? How soon can I be tested? How long will the testing take? Just to give you an idea, you may already have a sense of how long this takes, but generally you're looking at least a couple of weeks to get those results back. You're measuring it in weeks rather than days. How might my treatment options change depending on the results? And then after the molecular profiling has been undertaken, what were the results? What do they mean? What are the implications? Are there any targeted therapies? And particularly, are there any trials? Because of course, I mentioned in the previous slides that at the moment, there's only a few of these mutations which we can target, but there are a lot more mutations which happen in cholangiocarcinoma, and a lot of those are being looked at in trials. And if that information is there, I think it's worth looking into the options to see if there are trials available for them. And then following on from that similar theme, what happens if I don't have a mutation which can be targeted? And in many cases, that will be a discussion about things like trials. Next slide, please. Now, I'm in a really privileged position because I sit in a really, really big hospital. And because there are so many pathologists in that hospital, we can be really, really specialized. There are probably about 5, 6 people in England who do the same job as me. And that's a really privileged position because it means that I can look at things in a lot more detail than I otherwise would be able to. A lot of my colleagues, though, are working in much, much smaller hospitals and they're having to cover huge amounts more. I deal with 2 types of tumour, essentially. Many of my colleagues in smaller hospitals will be dealing with dozens and dozens. And they could be an absolute genius. There is still no way that you can be completely up to speed in complete detail on all of those tumours. And that, I think, emphasises the point that cholangiocarcinoma is still relatively a rare disease, not quite as rare as we thought it was, but still a rare disease. And it does require specialist knowledge. And because your general pathologist, your general oncologist who's dealing with lots and lots of cancer types will not see cholangiocarcinoma all that frequently, it's not unreasonable to think that maybe they may not be up to speed with all of the latest developments. And that's why I think referrals are important. And obviously I'm coming at this from the pathology side of view. You will not meet a pathologist generally, but we do the same thing. So cholangiocarcinoma pathology samples often will go to an expert cholangiocarcinoma pathologist to look at, to give their opinion on these things. I would say don't be afraid to ask for a second opinion in this regard for the reason I've said. It's difficult to stay up to speed with this stuff if you're having to juggle it alongside lots and lots of other things. In general, we try in the NHS to offset the impact of that by making decisions as a team. So you will be managed by a multidisciplinary team, an MDT, which will include people from lots and lots of different specialties who will come together to discuss your case to decide what is the best thing to do in your individual situation. Next slide, please. Wow, I went through that pretty quickly.
It's brilliant. Really appreciate you going through those slides. We will have a Q&A for those of you at home. I can see lots of questions coming in. We will come to them in the next part of the webinar. But before we do so, I would just like to give Kevin and Ilona the opportunity, as 2 patient advocates in cholangiocarcinoma, to ask a few questions of Matt and Chiara. So Kevin and Ilona, I will hand it over to you. That's okay, and you can ask a question.
Thank you. So maybe I'll start. Thank you very much for this presentation. Very kind of really comprehensive, because genetics and kind of this kind of knowledge really goes over my head.
I think it does with all of us.
Thank you. So in my case, you've mentioned those two types of testing, blood sample and tumor sample. In my case, I had a biopsy, obviously, at the beginning. I had my surgery first, but I also had something called liquid biopsy, which was the blood test. And my question is there a difference, and is one better than the other? You sort of mentioned maybe, are there any issues with any of those methods? Could you just dive a little bit deeper into that?
Yeah, it's a fantastic question. It's kind of the one that everybody is asking at the moment because it's such a hot topic. I don't think either one of them is the better option. I think it kind of depends what question you're asking and what situation you're in. So a biopsy, that has the advantage of giving you not only the profile, but also obviously gives you the diagnosis, which you wouldn't get necessarily from a liquid biopsy. The biopsy sample, if you use that for testing, you're generally less likely to miss things, although that's simplifying things a little bit, but generally you're less likely to miss things. It also allows you to identify things which may be hard to detect on a liquid biopsy. So for example, HER2, one of the things which is potentially coming in future, there are some issues around that with liquid biopsy. But liquid biopsy is really, really good, at least from one perspective, in the sense that obviously it means that you don't need to have an invasive procedure to have it. So even a patient who's very, very poorly, a patient whose tumor may be very, very hard to access, you can still get potentially some profiling with it. It's also very nice from the point of view that if you put a needle into a large tumor, you're only looking at really a very, very small bit of what's potentially quite a large disease. Now, usually the tumor will be the same all over, but you can sometimes see differences in different parts of the tumor, which means that you might miss things by just putting a needle into it. Whereas if you imagine your blood, you're kind of pooling everything from all of the tumor into your bloodstream. And that means sometimes get over that issue of differences between different areas of the tumor. So I think in an ideal world, patients should have both because I think they both have different strengths and weaknesses and they're complementary.
Thank you, Mark. Can I just
Yes.
jump in and ask a further question? I mean, it is more as a follow-up to your brilliant answer you've just given. Can you comment on the difficulty of picking up fusions, for example, able to determine the eligibility to FGFR2 therapies? And also, I think it would be nice if you could comment on the availability as a certified test around the country, as doing the test is only one step, and do it through specific criteria that we can use to select the therapy is different. So can you just highlight which kind of test is available at the moment?
Yeah, so going back to your first question, which was about picking up fusions. So fusions are the kinds of things which we look for with FGFR2 and a few other things as well, but mostly FGFR2 in cholangiocarcinoma. Historically, liquid biopsy has kind of been a bit rubbish at picking up fusions for various reasons. The thing is that these tests have come on a long way, particularly in the last 2 years or so. The technologies have improved dramatically to the point where actually, depending on the test that you're looking at, the fusion detection is now not hugely below where it would be for a tissue biopsy. Still generally lower, but very impressive for some of these tests. I don't think we'll ever reach the point where the liquid biopsy is absolutely on a par with a tissue biopsy. I think it will always be a little bit inferior. But I don't think we're in a position now where we were maybe 6-7 years ago, where we would say liquid biopsy, no chance, don't even bother, it won't work. You will pick them up, but you will miss some. And that's why I think it's important to take the view that a negative liquid biopsy result is not a negative result, it's an inconclusive result because it can miss these things. And then the other question you asked was about the availability of liquid biopsy tests. Now, again, I can speak for England, but at least in England, and I think it's true of all the nations of the UK, at the moment, routine liquid biopsy isn't funded on the NHS for cholangiocarcinoma. In England, it has just been funded for lung and breast cancer. I know that biliary cancers are on the list. I think they're the next or the one after that. It's hopefully coming very soon, although these things do take a while, as you would imagine. So at the moment, unfortunately, at least in England, the only routine option to be able to get hold of these tests is through the private sector or potentially through an NHS laboratory, but it wouldn't be through an NHS charging mechanism. There are lots of different providers out there. I don't know if I'm allowed to name any of the providers, but if you Google liquid biopsy, you will come up with some commercial providers. There are lots of them around. And I can tell you that the Marsden and Manchester genomic laboratories, which are NHS laboratories, use the largest and most popular commercial assays. So if you Google,
I think, Matt, if I can jump in there, if I can ask you afterwards, so you don't lay yourself open to any legislation matters, if you could let us know who you consider, who's the Royal Marsden using, who are really good, because that is what patients will be asking us.
Absolutely.
And I really think we should be able to share that information with them. So I'd really appreciate it. Did you finish with Chiara's answer? Because I've got a bit of an extra question that really goes on to Ilona, the discussion Ilona has opened, which was great. Thank you so much, Ilona, for that. It was really fantastic. It's just, if you're looking at a tissue biopsy, in general, it's very difficult to get tissue biopsies from cholangios for a number of reasons. But depending on where the biopsy is taken, you might find one mutation. Is it possible that within that same cancer, there could be more than one mutation? And even if you find those, how does the oncologist know which ones to treat?
Another really good question. And I guess I should split it into two parts. The first part is a patient who hasn't received any treatment. So they've got a new diagnosis of cholangiocarcinoma. In that setting, if you do genomic profiling of that patient's cancer, you will inevitably find normally lots of mutations. In general, though, we tend to describe mutations as being drivers and passengers, which is kind of what it sounds like. So the drivers are what drive the cancer. And if you inhibit a driver with a drug, that's likely to have a beneficial impact. Passenger, that's just kind of coming along. It's not really doing very much. So if you give the patient an inhibitor for a passenger, that's not generally going to do very much. Generally, in a patient who hasn't had any treatment, you will only have one of those key drivers which you can inhibit. It's incredibly rare to have, say, FGFR2 plus IDH1. It can happen, but it's very, very rare. And I don't know if Chiara has ever come up against that. Oh, wow.
Yes, I mean, we have had a few cases. Well, actually, no, we had only one case where we had both the mutation and the fusion. And that is potentially an ideal situation where you can choose for different targeted therapies. And obviously depends on some clinical conditions, which priority to give to which treatment. But obviously, as you said, this is a rarer condition. So more routinely, they are single. The clone or the driving mutations and alterations, they are single. And those alterations, they don't tend to change over time as well.
The second setting is a patient who's been on treatment. So, for example, a patient whose cancer has an FGFR2 fusion as a driver, they go on to an anti-FGFR2 drug. If you then test their tumor sometime later, you'll often find new mutations have developed. They may be relevant in the future. I think it's fair to say, and Chiara, please do disagree with me if you feel otherwise. At the moment, that doesn't routinely change treatment, but it may have an impact on trials and it may mean something in the future.
That's interesting. Thank you. But this is Kevin and Ilona's session, so I don't know if Kevin hasn't had a chance to speak yet. If you want to come in there, Kevin, at all?
Yeah, thank you, Helen. So it's a really interesting topic of conversation. I mean, I've got a number of questions. I'm sure we'll start to work through some of them. I guess just picking up on the point you made a minute ago, that a negative test is really an inconclusive test. And my own personal experience, I went through a liquid biopsy, didn't find anything. Went through tumor biopsy, didn't find anything. Subsequently, in my journey, had another biopsy and found something. So if you do get a negative test, are there points in someone's journey where you might recommend a further relook at someone's biopsy results and molecular profiling?
It's a really tricky question. I think when you're, and it's easy for me to say because of course I'm a pathologist, I'm not a busy oncologist seeing lots of patients in their clinic, but I feel my sense would be that when you come to a fork in the road in a patient's care and you're presented with a major decision about whether you go down one road with one treatment or one road with another, I think an optimal thing to do at that point would probably be to stop and have a look back at the testing which had previously been done. Because as I mentioned earlier, not all tests are the same and no test is perfect. And some tests may be faster and they may have higher success rates, but their coverage may not be quite as good as we would like it to be. And there are very good reasons that you might need to do that. You know, you may need a very fast result and that may be a completely appropriate thing to do. But I have seen a few cases, admittedly not with cholangiocarcinoma, where a patient had a test done initially, nothing was found on it. Subsequent testing with a slightly different technology did identify something. Now, this is very rare. It happens very, very occasionally. But it can be that the original technology maybe didn't have the comprehensive coverage that we assumed that it did. And I think in those cases, it's worth firing off an email to the genomic lab which did the test and just asking, you know, how sure are you about that result? Because it's never going to be absolutely 100%. No technology is perfect. But sometimes there can be enough doubt for you to say, okay, let's take that DNA, which is frozen in a freezer. That DNA will be stored forever, or RNA, or whatever it is. Let's take it and rerun it on a new panel just to see whether anything comes up. Obviously, that's an ideal world scenario. I'm very conscious that my clinical colleagues have huge amounts to do. And of course, if they're stopping and doing this all the time, it's going to be very difficult for them to operate. But that would be my view. But I'll defer to Chiara because I think she's probably best placed to answer this.
Well, actually, I completely agree with you on the fact that this is a decision that is based on the feedback between the oncologist and the discussion between the oncologist and the pathologist. I think we have to be clear what we mean for negative test. Does it mean that the oncologist has said is negative and we mean there are no druggable alterations? So they have found some alterations, but there is not a drug for that specific mutations. Or very, very few cases I've seen completely negative, so they haven't found anything at all. So in the first case, it depends on the kind of cholangiocarcinoma we are looking at, and we definitely need, we still see that half of our patients don't have a mutation for which a drug exists at the current time in the NHS system. It's different when the test maybe didn't have the possibility to be completed in full. And I'm thinking to all situations where despite having a tissue biopsy, there wasn't or not enough tissue, or it had been used before, and so they finished the tissue to do all the extensive molecular analysis. Or maybe there weren't a lot of cancer cells because cholangiocarcinoma might have a lot of other, different types of cells that can bias the result. So that is, for example, one case where with no hesitation, I ask a patient to redo another biopsy, especially if they are intrahepatic cholangiocarcinoma and we know that there might be an enrichment in finding those molecular alterations. If I see that the tissue was not good enough and the pathologist didn't have enough material to do all the analysis that should have done, that I think is one of the moments where it is good to put the patients through a risk of biopsy, which might have some complications because the results we might achieve are greater. As for the liquid biopsy, if it is negative, I don't think you can say that everything is negative. So that if there is the chance to send for a tissue biopsy that in genomic profiling, that's something I would do.
One thing that I would like to emphasize, just because it's my hobby horse, is before going for another biopsy, and I'm conscious there probably aren't very many clinicians on the call, but if there are any, please do talk to your pathologist before you go for the next biopsy, because it may be that we can go back to what was done originally and we can get the information that we need out of that, which spares another biopsy. Not in many cases, but in a few. So I think it's certainly worth having that conversation.
Thank you, Matt. Just a follow-on question, Maria. For your slides, you talked about how over time mutations can change. Mutations in the cancer can be added to. Where there is an instance of recurrence or metastases, are the mutations always the same as the primary?
So you'll almost never lose mutations. It can happen in some tumor types, but it's rare. In the case of cholangiocarcinoma, if we're talking about a driver, that driver will be maintained throughout the evolution of a cancer. There will be more things potentially added on top of it, but that theme will continue to run through in pretty much all cases.
Can I just add a comment on that answer? I think that when you have a tumor that has been resected, first of all, you have the possibility to look at a large space. And so you have the possibility to look a little bit more in depth. But also you have to think of that like a puzzle. There are different pieces, different cells, and it might be that each one of these cells or clones or group of cells, they do have a specific molecular alterations. And when the tumor comes back, at times we tend to see that one of these pieces is more represented than others. So this is why what Matt was telling about liquid biopsy can be useful, because it gives you the idea which part of the piece of the puzzle is actually now driving the growth of the cancer. And so most of the time, what we know, however, is that the mutations for which we have drugs, they don't change. So if you have one of those IDH1, FGFR2 alterations in the surgical specimen, and if the tumor comes back, you still more likely have the possibility to grow through that treatment.
Can I just ask one follow-up question? Because it's all really interesting. So the driver stays the same, but the mutations, so the passengers can potentially come on board, is that right? And if one treatment is kind of stopping the driver, is it possible that another passenger becomes a driver and then the drug doesn't work? Not because the original driver is not stopped by the drug, but because another passenger is taking over?
Yeah, you've hit the nail on the head.
Okay.
Yeah, you'll get these extra mutations cropping up over time. And if one of those mutations happens to give that particular cancer cell an advantage over all of the other cells in the tumor, then that cell will grow more quickly and it will eventually become the dominant clone, if you like, in that cancer. It's called clonal expansion, if you want the technical term for it. Very much, it's natural selection, essentially. If one mutation gives a slight advantage, it expands, but that original mutation will stay there. It will just, I guess, become less important over time as the other ones become more important.
Something very similar can be said, Ilona, for the FGFR2 therapy. This is probably one of the situations we know at best. So you have your FGFR2 alterations that you are targeting with your drug, but the cancer learns how to change that specific structure so that the drug doesn't bind anymore. So the driver continues to be the same, but in reality is this new ancillary mutation that make that tumor become resistant to the specific drug that has been working for a while.
Okay. Thank you. Interesting. I have a question, unless Kevin, you have a follow-up question.
You go first.
I was wondering, because the list of different mutations, it did contain also or include a mutation called BRCA1 and 2, and I know that this is relating to breast cancer. Is that right? It relates to different cancer, and it's also it's possible to inherit that mutation. So I guess my question was, are there any other mutations that can be inherited, and therefore should potentially our family members be also tested for any mutations?
Yeah, again, a really good question. In principle, any mutation could either be acquired, so you develop it in the course of your life, or it can be inherited. Now, cholangiocarcinoma, it certainly can occur as part of a familial cancer syndrome, so like BRCA, which you mentioned. It can also occur in the context of things like Lynch syndrome, which is another one of those familial cancer syndromes. It's pretty unusual in cholangiocarcinoma. Vast majority of cases of cholangiocarcinoma occur sporadically. Having said that, though, and that's why, for things like endometrial cancer, for colon cancer, we routinely screen all of those automatically to see, could this be part of a familial cancer syndrome, because it is actually quite common. Because biliary cancers are not in that category, we don't take that approach. But that doesn't mean to say that you should completely ignore the possibility. And my view would be that if there is a worrying family history, if there is a lot of cancer in the family, then I think it is worth having a think about that. And maybe a clinician in that situation would consider the possibility of sending a patient to see a clinical geneticist to have germline genomic testing, which is what we call it, where you're looking to see if you've got any inherited mutations.
Thank you.
Thank you. So I guess my question moves away from diagnosis, and Matt, you may or may not be able to answer it. May have to go more widely, but I guess one of the questions that comes to a patient's mind is, if you are aware that you have a mutation that is targetable, why wait until second-line treatment to receive it? And I suspect that's a very complicated answer, but it is something that immediately sparks with patients.
Yeah, and it is frustrating. My understanding is that it all comes down to what was possible in terms of the trials, because of course the drug regulators will only be able to license things according to how they were done in the trial. If you have a drug which is used in the trial in second line, then in general that is how it will end up being licensed. And as I understand it, and I'm sure, sorry, I'm deferring lots to Chiara here, but I'm sure she will know more about this than I do. As I understand it, it has been difficult to do first-line trials in the context of cholangiocarcinoma for targeted treatments. And my understanding is that that is the reason for it. But I mean, if Chiara would like to come in, then I'd be very
Yes,
happy to hear
I
her
would
view.
probably say that there are two different reasons. One is regulatory. So initially, if we have a trial, the trial is a safety net for patients, okay? Because we don't want to go around and just start to give, if someone wakes up and says you can take zinc because that will cure cancer, then patients can just be harmed by that. So we need to provide evidence and support that that drug works. So we have trials, and if the trial is given the drug in second line, that is where the regulatory approval will be given. So we can't then just change it unless there are specific situations. The reason why these trials are often done in second line first is because when you have a new drug and you bring that drug from the laboratory to the clinic, you don't know if that drug is going to work. And you never want to put the patient at risk of not receiving something that can work, even if the chances might be smaller, but we know that works, for something that actually could even potentially kill the patient without benefit. So the trials usually go through, a different phase. They usually go through patients who have had treatment, approved the treatment before, and then if they are proven efficacious in second line, then a new trial is designed in first line to see if we can advance, that treatment. Having said this, at the moment, as per regulatory, we can give it only in second line outside research. But also, I think that we don't know if necessary those treatments will work best in first line. There are some situations where the chemotherapy can actually, even if it doesn't change the main clonal, the main driver mutation, but it might affect in some way the rest of the way the cancer cells interact with the microenvironment and then can change the response. Or is even true that at the moment there is a lot of still investigation to understand how these different molecular alterations can impact the response to first line. Because there are some of these mutations that we know they make the cancer more resistant to the usual chemoimmunotherapy. So in those cases, there is more rational to go first. There are some other cases that actually might have a good response to chemoimmunotherapy, and you don't want necessarily to lose that, or at least you don't want to lose it because it depends on what you can achieve with the targeted treatment. It's really a matter of balance, of putting things on the scale, understanding what you can achieve with your targeted therapy and what you can achieve with your chemoimmunotherapy in each different situations. And for example, the new studies that is currently open in UK, the ABC10, is looking at doing an induction phase of chemoimmunotherapy anyway at the first, and then switching to a targeted therapies in second line. Someone can argue that because we have seen some very good potential in shrinking tumor down with some of the targeted therapies, with not all of them, but with some of them, there might be a role of doing them a little bit more earlier in first line, because if you don't have any other metastatic disease, because maybe we can shrink the tumor down to a level that surgery then can be offered. But unfortunately, we need to prove this evidence before we can bring it into the NHS.
Thank you, Chiara. That does take us to the end of this part of the webinar, the moderated discussion. There is still going to be questions and answers. We are now going to open our floor up to the audience. And again, thank you to everybody who's been submitting your questions in. It's brilliant. So if it's okay if I start with one, I know Helen and Chiara and Matt, you'll also have your own questions to ask, but if I could just start with one, I would say it would be good to go to Chiara. If your consultant orders genomic testing for you today, how long would it normally take to get results? And is this different for a blood sample and a bit of tumor?
Well, actually, this is the perfect question for Matt. What I can tell you is that it depends on probably where you live, because it's a laborious process. It's not something that can be done very quickly, but I think it depends on the workload of that area, of that genomic hub. Usually these tests are kind of centralized in some specific areas around the country. So it depends on the technology they use, it depends on the number of patients that they have to go through. It can vary, and probably can go from 2 weeks to 4 months. So that's something where definitely there is area of improvement. For what relates our region, in Scotland still we are reimbursed from the NHS to do only a part of the profiling, and but even when we do the half of the profile, or when we do it for research, at the moment we can provide the results between 2 and 4 weeks, depending on the test we are looking at. Because I think one thing that we haven't mentioned is that nowadays we should send also 2 different tests. One is looking at the DNA that Matt has explained very nicely, and one is looking at the RNA that give us a little bit more information on the FGFR2 pathway, and that takes a little bit longer. But Matt, you're able to comment a little bit more about the technical times.
No, I completely agree with you. In England at the moment is generally hovering in the 2 to 4 weeks bracket, as you say, depending on exactly which of the 7 genomic laboratory hubs your sample is being tested at. In England, the goal which we've been set is to go from the point of having a biopsy to the genomic results being available. So this isn't just from the point of the test being requested. This is from the biopsy happening to the results being available, 14 days. That is going to be enormously challenging, and this is taking up a lot of my day job at the moment, but that is the ambition. And actually, when we've mapped it out, it is feasible, albeit very, very difficult. There was also the question there, I think, about how does that compare between tissue and liquid? In theory, you can do liquid a bit more quickly. In reality, what we're seeing in England in the work with lung and breast so far is that actually there's not a huge amount of difference in terms of how long it takes. The real benefit with liquid, though, is that you can start it sooner. So you could take a blood sample when it looks like it's probably going to be a form of cancer on the radiology, which means that it could potentially be several weeks before the biopsy even happens. That means that you could potentially be in a scenario, at least for some patients, where you identify an FGFR blood before the biopsy has even happened. And we're now seeing that with lung. We're finding targetable mutations before the patient has had a needle in their chest. And I think that has to be the goal, because then pathologist looks down the microscope at the biopsy, says, yes, this is cholangiocarcinoma, and you're good to go. That will reduce delays massively.
Thank you, Matt. And then, Chiara, you mentioned some differences between England and Scotland, and that there are a few questions on the healthcare in Scotland. One question I would like to ask is, what are the practical steps for getting the full panel of molecular testing, either privately in Scotland or through a trial in England or Scotland, or is there some other process that patients could follow?
I mean, in Scotland, we do have the same drugs which are approved in England, which at the moment include the ones that Matt has explained, so pemigatinib, futibatinib, and ivosidenib. And there is also around the UK an agnostic approval for NTRK2 inhibitors. And we can screen for these molecular alterations in Scotland, so each patient should be available, should be recommended to be sent for a molecular profiling. What we are not funded to do in Scotland is a full DNA sequencing. So we can look at specific genes, we can look at the FGFR2, we can look at the NTRK, we can look at the IDH1. Through some of them are reimbursed through the NHS, some of them are through a sponsored program. But what we need to do is that with one go, we tend to do all these tests together, and we can add a lot of other genes that can make things feasible, reimbursed through the NHS. So if you are a Scottish patient, wherever you are seen in Scotland, you should ask for molecular profiling, because at least you should have the possibility to be screened for those molecular alterations for which drugs are available. If we want to go outside and get a full genomic profiling, there is either the options of research. So a lot of different centers in UK as well. Here in Scotland, we do have research programs for which we can offer, in selected individuals, the profiling. And then there is also the option of private practice, which can be facilitated, by us as well.
Thank you, Chiara. Helen, I don't know if you would like to add anything on this, just based on the event last week in Holyrood.
Well, thank you. Yes, thank you very much, Chiara. AMMF had an event just last week in Holyrood, the heart of the Scottish government, to draw attention to what Chiara has just explained. The inequity that there is, or that exists currently, for those with cholangiocarcinoma in Scotland and against the rest of the UK. And we were very fortunate that we did get listened to, and we're keeping every digit crossed that hopefully we may get some good results from the asks that we've made when we were at Holyrood, and that we will achieve better for our cholangio patients. So just a little add-on to what you were saying, Chiara. So if you have a patient that you would like to do a full panel for, at the moment, do you have to say to them, well, if you want this done, you have to pay for it privately? And if so, is it available in Scotland, or do they have to go to England or wherever?
So if there isn't any research program that we can offer to the patient to fill the gap, yes, we can offer the patients the opportunity of private test, and they don't need to go to England. In sense, they can. We have happened to have this discussion with some of our patients, and there are some commercial partners as well that you can get access to. Usually, it comes through the oncologist, and so it's a little bit of work for us to refer, but I mean that is kind of an easy pathway to follow, and we are all quite familiar.
Well, at least there is that. I mean, it's very unfair for the patients, but at least there is that. So there is a lot of interesting questions coming in on the Q&A list. But if I can just stick with Scotland for a moment, what can Scottish patients do if they see a clinical trial they consider they might be eligible for that they can't get onto in Scotland? Can you then put them forward for the trial that's happening somewhere in England? Can they do that?
Yes, and this is something that we routinely do. I mean, I have a lot of patients who actually have gone through other sites of the country for trials. The situation at the moment in Scotland and in UK in general is that you can't move from one area to another, not even within Scotland, if you just want to access routine approved drugs. So that is where it's sometimes called as a postdoc lottery, because in reality there shouldn't be a lottery. I mean, all different patients should have access to the same treatments. But if there is a trial, an option somewhere else, and this is true from Scotland to England, is true from Edinburgh to Glasgow, or Glasgow to Edinburgh. A lot of my patients go to Edinburgh, for example, or they come to me from Edinburgh. And in this case, you can refer them to England, and this is not going through a private practice. This is going through the NHS. There will be a support because it's something that cannot be provided in that region of interest.
Okay, thank you. So when you say support, do you mean they would have their travel funded, or they're just allowed to do it?
They are allowed to do it. I don't think that there will be support for traveling, but they don't have to pay for the healthcare access, which otherwise would happen.
Thank you very much. Thank you. So back to you, James, if you want to pick out another question to put.
Yeah, I mean, we've got lots coming in, which is brilliant. So I might just change it up a bit and go back to Matt on this one in terms of, how do we identify the driving mutation on the genomic profile test? Is it on the VAF percentage, which, going back to my biology days, is variant allele frequency?
Absolutely. So I guess there's kind of the practical answer to that question, there's the theoretical answer to that question. And I think the practical answer to the question is, well, it depends if there's a drug available for the mutation which you found. And actually, as we've already said, it's a relatively small number of things which can be currently targeted. So actually, it's a relatively easy process to look through what has been found on, say, a next generation sequencing panel and say, okay, that is something which can be targeted. If you want to know in general terms, is something a driver, be it targetable or not at the moment, then things like VAF are useful. So VAF is effectively what percentage of copies of the gene in question harbor the mutation which you're interested in. So it's generally, well, it can be, but it shouldn't in theory be more than 50%, because you have one mutated copy and one non-mutated copy. That's not always true, but generally it won't be higher than 50%. If you've got it only present at like 0.03%, it's probably not driving the cancer. If it's present at 50%, then you think, okay, the cancer is really, really relying on this mutation. it's important. There are lots of little asterisks after everything that I just said, because there are loads of little exceptions to it. But in broad terms, that's one way that you could do it. And I guess in principle, that could be useful from the point of view of trial enrollment if you want to know how important a mutation is. In general, I think the question in trials is generally, is the mutation present or not? And if it is, then you're eligible.
Even if we just focus only on clinical practice without trials and research, at the moment, I mean, to be able to prescribe and provide a targeted drug, because there might be a chance that the patient responds to that, we just need to have the presence of the mutations. So we don't care about the VAF as long as it, goes above criteria of reliability. And in that case, it means that there is the chance that there is that group of cells which are expanding and driving, and then the targeted therapies might have an effect. What we don't know yet is if the response to that targeted drug will vary according to how many cells with that specific mutations are in the body in that moment. And this is all part of research. As well as part of research is actually looking at how the response to a specific targeted therapy can actually depend on the change in VAF of other molecular alterations as well. And I don't know, Matt, if you want to comment about, germline mutations and which kind of VAF, you see in those cases and what can raise some questions for the patients.
Yeah, again, having a very high VAF, it can be an indication that you may be dealing with a mutation which has been inherited, because if you think about it, each cell in your body has 2 copies of each gene, more or less. One of them inherited from mother, one of them inherited from your father. If, say, the copy which was inherited from your father is mutated, then it means that 50% of all the copies of that gene in your body are going to be mutated, which means that the VAF for that mutation will be pretty much at 50%. Having a very, very high VAF like that does raise the possibility that you may be dealing with a germline mutation. So, for example, going back to the question about BRCA being inherited, if I got some results back from a cholangiocarcinoma and there was a BRCA mutation and it was present at 3-4%, I wouldn't be too worried about that being germline, as in inherited from the individual's parents. If, however, I found a BRCA which was present at 50%, I would be quite worried about that. And I would then be saying, okay, this raises the possibility that it may be germline, it may not be, not always, but I would be raising the possibility. And I think that patient would need to see a clinical geneticist to see what's going on there.
And if I can just, add on comment to conclude the germline discussion. I mean, when you have this kind of genes like BRCA or genes of the mismatch repair pathway, HML1, the Lynch syndrome, then we tend to refer to the clinician, to the clinical genetics anyway. And then they will be the ones who can advise the families if a genetic test for the family is recommended or not.
Thank you, Chiara.
Can I jump in with a question?
Of course you can, Ellen.
Paraphrasing one that's come in on the Q&A section. If you have surgery and you do achieve clear margins, and then you go on, maybe you have your chemo or what have you, and you're considered in remission, you're free of disease, NED, as they say, should that patient have their whatever has been resected, should that be profiled so that they've got in the bag, as it were, knowing what mutations they might have had, so should they get a recurrence, they can hit the ground running with a targeted therapy?
Can I take this answer on, Matt? It's very dear to me. So, I mean, we always have to think that in medicine, we need to do tests when they can help us to decide something. And this is true for doing CT scans, this is true for doing blood tests, and this is also true for genomic profiling. Now, I think we have learned from our Scottish Parliament event last week and your Westminster event last year that we are in an area, and maybe will always be in healthcare system, of really tight issues with money. So whenever we go and ask for money, we have to really be very solid in having backup evidence of whatever request we want. So if a patient has a tumor completely resected out, that patient in cholangiocarcinoma still has a very high chance that the tumor might come back. But in the current scenario, that risk, is about, in the worst case scenario, 60%, which means that we have out of 100 patients, 40 patients who will never see their tumor coming back. And if I go back to the NHS and I ask them to pay for something that will never turn into action, they might just tell me, well, actually you are wasting our money, and I could have used those money to profile a patient that actually might get access to treatment straight away. Especially now, and hopefully the situation will change in the future, but especially now where the targeted therapies are reserved in second line, which means that that patient in the, even if he relapses, he has to go through another treatment first. So obviously, we all try to adjust our situations according to the local ecosystem. So in Scotland, quite lucky, I know that if I have to request a genomic profiling, in 2 weeks I will have the DNA sequencing result of that patient. So to me, it doesn't make any difference if I wait when that patient relapses. If you go in some other places, I don't think this is the UK scenario in any cases, but in some other countries it might be that you need to take many months to get the results back. Well, in that case, you can start thinking when to request your genomic profiling. But my personal suggestion is that you don't necessarily need to have it after your operation, because that is not something that at the moment is impacting on your treatment. Maybe in the future it will, and there is a lot of discussion about doing trial with targeted therapy in patients after the surgery, but at the moment is not something that will inform the decision.
Can I throw some controversy in there? I don't disagree with anything that Chiara said there. I should say that first of all. And the reality is that if you do lots and lots of testing for patients who will never need a result, you will slow down the testing for patients who need a result quickly. That's inevitable. However, my problem with it is that I, as a pathologist, don't know how urgent a result is until it's kind of too late. And therefore, the best way to make sure that you're getting the results on time for everybody who needs them is that I just request genomic testing, that I make the diagnosis of cholangiocarcinoma. Now, I also think that has diagnostic utility. I think everybody's aware that cholangiocarcinoma is actually quite a difficult diagnosis to make down the microscope. There's nothing really that tells us, yes, this is definitely cholangiocarcinoma, rather than something coming out of the liver and going into the liver. Genomic testing will help you a lot there if you're not sure what something is, or you think you know what it is. I've had quite a few scenarios, and I've presented them at AMMF meetings before, where I've been proven completely wrong by the results of genomic testing. Admittedly, not many, and I like to emphasize it's not that many, but they do happen. My view is that I think that we should be building health systems which can accommodate the volume of testing required to test all cholangiocarcinomas up front, accepting that that is money which is hard to come by at the moment.
Yeah, because many times people don't have time to wait, do they? They need to be tested. But it's interesting to look at it from both sides of the equation. But from the people who've put their questions in the Q&A box tonight, and from AMMF's point of view, we look at it from the patient's point of view, and that's forget the money, because it's what's best for the patient, I think, really. But I know from an oncologist point of view, a pathologist point of view, you're immersed in how can I get this through, because it's not going to get funded and I'm going to get turned away. So it's an unenviable balance.
Can I just say that anyway? I mean, it's far from me to suggest that someone has to wait the progression to first line to submit a genomic profiling. I mean, the topic, the discussion was about resected specimen in
Oh,
some
yes,
who has
yes,
not had
yes.
anything.
Yeah.
But I mean, even, you know, you always have to get a compromise. And at the moment, I think that there is a cost effectiveness in anyone who is eligible for treatment to go for genomic profiling, but eligible for starting a systemic treatment.
Mm-hmm.
The problem maybe comes from my experience, where we tend to see that about 25% of patients, despite coming to see an oncologist, they are actually not fit at all for treatment, because maybe their drainage is not good enough, or because, you know, there are some big comorbidities. And even though there are some cases where targeted therapies have a different toxicity profile, and so they can go ahead with targeted therapy and not with the chemoimmunotherapy, and I've had a few of those patients. Generally speaking, I would say that overall there is about at least 50% of patients, if I start to do reflex testing in my ecosystem, that wouldn't really be acted upon.
Okay, thank you for that. That's really great. We've got I think we've covered a multitude, but there is something I want to ask, and I'll ask it of Matt. I think it's a question that's come in on the Q&A, but I think it's a really interesting one at the moment, and it's around AI. And I have to say that until relatively recently, as far as AI in medicine, etc., was concerned, I was a complete Luddite. I was just thinking, don't let it anywhere near diagnosis or anything like that. We need a human on this all the time. But actually, I saw some work, had a little private presentation. Actually, it was very privileged to have a private presentation by some young researchers in Edinburgh who have been working on AI in the diagnostic area of cholangiocarcinoma. I was completely blown away. I mean, it was phenomenal. And I just wondered if, coming to the question, can you see a use for AI in the pathology world? And do you think it will speed up the testing, either in tissue or in the liquid biopsy?
Absolutely. And I think this is the most exciting thing that's happening in pathology at the moment, and probably the most exciting thing that's happened in pathology in, I'm not even exaggerating, probably the last century. So that degree of change that I think we're going to see. And it, I think, will impact on every step of what we do. But one very mundane example, which I can give you, at the moment, pretty much every pathology department is overstretched. And there are currently slides sitting, waiting for pathologists to look at them. Maybe a day, maybe a few days, potentially even weeks until a pathologist gets around to looking at them. Most of those will have been triaged so that they should only be benign things where patients can wait. But sometimes you will get nasty surprises in them. You'll have a case which has been sitting, it looks like it should be fine, but it actually contains a cancer and it's been waiting there for 3 weeks to be reported, which is clearly a catastrophe. What some departments are doing, admittedly not I think in the UK at the moment, but certainly in the US, is that as soon as these slides are prepared, they're run through a scanner, runs an algorithm and gives a probability of cancer, the high probability cancer case, immediately to a pathologist to look at. And at the same time, the algorithm will also potentially request extra testing if it's needed based on its interpretation. So it's still a pathologist, still a human being doing the job, but it's the triaging and the prioritization, which is actually now being done in a much more sensible and logical way rather than just next one in the queue comes along and gets reported. That's just one example, but at every single step in the pathology process, there are relatively little changes like that, which I think will make the whole pathway a lot more sensible, frankly.
I think that sounds a eminently sensible way to go. Of course, it's all in the preparation of those algorithms to begin with, isn't it? They have to be, absolutely spot on. But then they don't get tired or eyes don't go blurry at the end of the day, do they, looking down the microscope? So, but also, I think the important bit which you've raised is to have the human being in there as well. To me, it's, although I can see this is a great future, it still is a bit scary to think it might replace a human. But I don't know, have you got any thoughts on it, Chiara, on AI in diagnosis, perhaps, you know?
Well, I think that AI is a very powerful tool that will become more and more integrated into our clinical practice. And I mean, I agree with Marta that especially in pathology, I think is maybe the area where it's more advanced in terms of applications, as well as radiology. There is an area very, a big area of investigation. What I think always we need to remember, and maybe, even the discussion today at the webinar just brought it up, is that the key point is really creating a discussion between the different, professionals. I mean, the way why we request the test, we interpret the genomic profiling, we have seen that we need to go back and forth. And this is something that we routinely do with our pathologists. And that probably is something that cannot be completely omitted or replaced by the AI. But some routine work, when we have the appropriate tool, that can be automated. And it will be very exciting to see, how that can probably enhance the possibility to deliver, a better healthcare system in a shorter time.
Yeah, that can't, the value of that can't be underestimated, can it? That's fantastic. I think time is running out.
Just that time, Helen. But
I think this has been a fantastic discussion. We've only touched on what we could have covered. And I think what we're seeing, from everything that we've heard about, is that such progress and such learnings are being made in the field of cholangiocarcinoma. It's hard to keep up with everything, but it's difficult because those that make policy, etc., are even further behind than perhaps the likes of AMMF is in keeping up with all of this. And it's really trying to push for better recognition all the time on where we are and what we're doing. Anyway, I'll hand back to you, James, because I know you've got a bit you want to do.
Yeah, it's, first of all, is it 2025 if we're not talking about AI? Seems to be the hot topic. Secondly, I think there are a few questions that were not answered this evening, so we will work to document them, and we'll create a document that lists the questions, and we'll provide some written answers. And Matt and Chiara, I know we've asked a lot of you, but we may ask you to provide your thoughts in writing on those, and we can upload them to the website. So if you did get your question in and it wasn't answered, we will get to it. I would like to mention that, as I said earlier, this is a series of webinars. This is the second. There is a planned third one on September the 24th at 6 till 7:30. So please do book that in your diaries. More information on speakers, topic, and registration will follow very shortly. So please do keep a lookout on AMMF social media and the website. I would like to also thank the supporters for this webinar, AstraZeneca and Saiho. And then I would also like to excitingly announce that AMMF, as of today, released a new document called Fast Facts for cholangiocarcinoma. This is available on AMMF's website. You can see the link here. It really does provide a one-stop shop for all of the information that you need on cholangiocarcinoma, from diagnosis through to treatment. So please do check it out. It's on the website, and you'll see it on social media very shortly. I would just like to say a big thank you to everybody at home, the speakers. I thought it was a brilliant discussion. A reminder that this will be available on AMMF's website. So if you did miss anything today, you can access it post-webinar. And then just to close this, Helen, if you could just give us a few words, that would be brilliant.
Thank you, James. Well, obviously, many thanks to Matt and to Chiara, your insightful answers and your knowledge is great, and we're so pleased to have had you with us, and also for Kevin and Ilona for being so helpful and helping with great discussions this evening, and of course to everyone attending, and for putting forward such great and insightful questions. As James has said, you will be able to view this webinar again. It will be on AMMF's website in due course, and we'll let you know via social media as soon as it is up on the website. And if you want to follow up on anything you've heard in this webinar, we do have a booklet and a video on molecular profiling in the resources section of AMMF. So as well as our brand new fast facts, we have a booklet and video on molecular profiling. And please do make a note in your calendars of Wednesday, September the 24th for our very next webinar. And thank you so much, everyone. This has been fascinating. Thank you.